So even though CTA, as you'll see in my conclusion, doesn't have much relevance to screening, I think probably most people here are not as familiar with CTA as they are with everything else, so I'm just going to give you an update on coronary CTA. And just to talk about the validation of different technologies. These are all the ischemia flow-derived technologies, SPECT, PET, stress echo, and MR. Every single one of them uses the cath as the gold standard. FFR uses, which is fractional flow reserve, uses nuclear ischemia and a stress echo, which also refers back to cath. The anatomical measures of disease are also based on nuclear ischemia, which is based on cath. Everything is based upon cath, including CTA, which I really don't think is correct. I think CTA should have intravascular ultrasound as the gold standard. The problem with cath is that cath correlates very poorly with the only gold standard that we could apply to it, which would be intravascular ultrasound. And so we have a validation paradox here in which the functional tests and IBIS area criteria are used to judge the anatomic gold standard by which they were validated. So it's a roundabout way of saying there really is no good gold standard other than perhaps outcome studies, and we're fooling ourselves on a day-to-day basis. So in terms of the use of CTA, let's talk about stress testing. This was an editorial a number of years ago. The relationship with stress testing will ultimately be decided by technological advances, complex negotiation, blah, blah, blah. This is sort of a press secretary release, spinning the issue, and who said that? I did. But I had to be politically correct, which I don't really like to be. And so let's talk about this. So CTA and stress testing. Indications for stress testing. Class 1, patients undergoing initial evaluation with suspected or known CAD, or these are all class 1 indications here. What's the accuracy of stress testing? Well, these are combined from multiple meta-analyses, nuclear sensitivity and specificity here, PET scanning, MR perfusion, wall motion, echo, standard treadmill tests. Let's look at the accuracy of CTA. These are earlier studies, 2005 to 2007, 1331 patients, sensitivities and specificities that far exceed that of the existing technologies. This is more recent studies, multi-center studies in 2008. This is pooled results here. Sensitivity 94%, specificity really brought down by one particular study. This one here was lower than I think it is in reality. Let's look at detection of disease in individual vessels and segments. There really is not much in the way of nuclear for proximal and distal. For CTA, we have excellent data. For all segments, 91% sensitive, 96% specific, proximal, distal, you see the numbers here. What about for individual vessels? Left main by nuclear, 85%, 100% by CTA. Proximal LAD, proximal circ, proximal right, far superior for CTA than for nuclear testing. Triple vessel disease is one of the downfalls of nuclear testing. I used to be a nuclear cardiologist, by the way. Still am, to some degree. So basically, nuclear imaging failed to identify 40% of the high-risk triple vessel disease patients. 12% had totally normal studies, another 28% had scans compatible with only single vessel disease. As Dan has shown, that nuclear misses 15% of left main patients, 10% being normal, another 5% being low-risk scans. And of course, these are precisely the patients you do not want to miss, even though they do not comprise a large segment of the population. Example, normal nuclear stress test, terrible disease everywhere. This is the CTA here, left main disease, LAD disease, severe RCA disease, and the corresponding cath. 72-year-old man with chronic stable angina, basically unremarkable. Patient had severe distal left main disease here. So if you look at the change from pre-test to post-test probability by SPECT, MPI, 2D echo, and coronary CTA, it's very clear that you get the most increase from pre to post-test using CTA. What about looking at the ACC National Cardiac Data Registry? In 400,000 stable patients, the incidence of obstructive disease, astonishing, right? 40% with greater than 70% stenosis, 41% greater than 50%, and 40% had less than 20% stenoses. The addition of the non-invasive tests had limited effect on the predictive ability over and above clinical risk factors and symptoms. This did not delineate the breakdown between the non-invasive tests, but clearly with existing ways of evaluating patients to triage to the cath lab, we're doing a poor job. And ironically, the editorial comment on this was, ironically, there's evidence that in many situations, a better gatekeeper test may yet be another radiographic imaging technique, namely multi-detector CTA. For example, the negative predictive value was 99%, making it a very promising gatekeeper for invasive coronary angiography. And this came from the group at Columbia that is very conscious about radiation exposure. Prognosis, nuclear stress testing, normal, 0.6% annual event rate. Stress echo, 0.9% annual event rate with increasing events with higher scores. What about prognosis for coronary CTA? James Nin very elegantly demonstrated that no matter how you analyze the coronary tree, as you have more disease on the CTA, so does your survival in your event rate increase dramatically. Matt showed the same thing, exactly the same thing. Increasing disease shows increasing event rates. In patients with suspected CADs, was 1,256 patients. Severe cardiac events in the absence of obstructive CAD, 0.1%, all cardiac events 0.5% compared to the presence of obstructive CAD. Prognostic value in another 2,000 patients, 0 scores. Adverse cardiac events 0.2%, increasing with the degree. And interestingly, the plaque score, looking at the different components of the plaque, was a more powerful predictor than ejection fraction or CAD severity. So this is really a unique contribution of CTA. Radiation doses, Nan's going to talk about this, but we do now have the ability to deliver sub-millisievert CTAs. First they do the nuclear stress test, and now they want a CTA after the patient is fried. Chest pain in the emergency room, this is a standard scenario. Multiple enzymes and EKGs. Scenario number 2, first set of enzymes normal, you do a CTA. Randomized study, 16 centers, 701. Low-risk chest pain patients. Diagnostic time, much quicker with CTA. Cost, much less. Not much difference in adverse events. CTA for rapid discharge of patients from the emergency room. 84% were discharged home after a CTA with less than 50% stenosis, 30-day follow-up, 0 deaths or MI. Fast track evaluation, discharged patients. Those subsequently coming back for angiography, 0.7% compared to 6.1% following nuclear, PCI 0 versus 3%, and readmissions 1.1% versus 5.1%. Importantly, cost and outcomes, CTA versus nuclear is the first test in patients without known CAD. Total healthcare costs, 27% less for CTA. Costs related to CAD, 33% less. Hospitalization length of stay, considerably less with CTA. And no differences in outcome using CTA versus nuclear. So the other major indication for stress testing is really the functional evaluation of the stenosis. And let me take you through the following thought process. If you know on a CTA that you have less than a 50% stenosis, and the nuclear stress test is positive, that is by definition a false positive test. If the nuclear test is negative, that's a true negative. If you have, going to the other extreme, greater than 75% stenosis, if the stress test is positive, it's exactly what you'd expect. And if it's negative, it's by definition a false negative. Remember, however flawed, we are still referring back to the cardiac cath. So the recommendation, my recommendation anyhow, is that the first test, the evaluation of the patient for coronary disease, for obstructive disease, because that's what we're doing here, is to do a CTA, and the only time you want to do a nuclear stress test, or any stress test, is after the CTA if you have an intermediate lesion, in which a positive stress test would lead to an intervention, given the appropriate clinical scenario, and a negative stress test would lead to medical treatment. So this is, I think, a fundamental change in the paradigm. Currently, most insurance companies will only pay for a CTA after an equivocal stress test. It should be the other way around. That the first test should be the CTA, and then a stress test only if you need more information. The relationship between CT and nuclear testing in the same patients, direct comparison, 114 patients here, sensitivity and specificity of CTA compared to nuclear, published in JACC. Another paper, 70 patients, published in JACC Imaging, sensitivity and specificity compared to nuclear. Anatomic correlates of normal perfusion scans, 97 chest patients with normal MPI. Only 40% were normal by CTA, 38% non-obstructive plaque, 23% had significant obstructive disease. CTA to identify patients with moderately abnormal nuclear and whom diagnostic path may be safely avoided without going through this. CTA can identify up to 80% of patients at low risk in whom invasive studies may be safely avoided. Another bonus is that ischemia does not define the anatomy and does not assist in specific planning. For instance, this is a nuclear scan demonstrating anterior ischemia. Well, that can either be a significant lesion in the mid-LAD there, or it could be this, a chronic total occlusion, and your approach to knowing this beforehand would be entirely different. Inferior ischemia on the nuclear can be either a tight proximal stenosis here, or it can be a total occlusion, easily diagnosed by the CTA. And you wouldn't do anything with this patient. You wouldn't take the patient to the cath lab. Now, as Dan has also shown, nuclear stress testing in coronary calcium, if you add up these numbers here, patients with normal nuclear stress test, fully 56% of them here have calcium scores greater than 100. So the nuclear test can be very misleading. This is paradigm shift, CTA before stress testing. Substitute CTA for stress testing for whatever information is sought other than exercise capacity. Stress testing is best reserved to establish the functional significance of intermediate stenoses demonstrated by CTA. And for those patients with arrhythmias, very high coronary calcified plaque burdens, or renal dysfunction that prohibits CTA. Who said that? I had the opportunity to modify my previously wimpy position. Now let's talk about CTA as a screening tool, which is what we're about here.
Okay, so we're going to move on.
I am. No, let me 2 more minutes here. This part's short.
Okay.
This is the relevant part. So, the advantages are you get the ability of the non-calcified plaque to the CAC, you can identify high-risk plaque, incidental identification of critical lesions, these are the disadvantages. Is there any additive value of CTA to a 0 calcium score? Well, we know that 5% of events are associated with 0 calcium scores, so can this offer us, can it supplement the ability to diagnose this? Well, we can identify ulcerated plaques very easily. 41-year-old asymptomatic female, 0 coronary calcium score, here's an ulcerated plaque. You can see protruding here. Is this one that's going to go on to cause an event? We don't know, but that's clearly classifiable as a vulnerable lesion. 35-year-old, 0 calcium score, followed with premature disease. Thank you.
That's a real warning.
2 ulcerated plaques right here. Again, I think we have to conclude they're high risk. Here's another patient with an extensive amount of non-calcified plaque, which is lipid laden. And to me, this is the CTA equivalent of the thin cap fibroatheroma. I don't know what else it can be. More examples, both ulcerated plaques over here in the same patient and a thin cap fibroatheroma. What about serial evaluation? I have grave doubts as to whether or not this is going to be effective with current technology. Here's a scan with a lot of lipid plaque here, TIPA. This is 6 months later, and it's basically unchanged, but we run into all sorts of technical issues with attenuation. Here's ulcerated plaque in a 67-year-old woman, right over here, and this part of the vessel looks normal. Here's the ulcerated plaque. And the patient starts off with an LDL of 118, put on Crestor. 2 years later, her LDL is 68. Well, the previously noted ulcerated plaque is not there, but she has a new one right here. And there is progressive disease in this segment. So this is a failure of therapy. 47-year-old male, calcium score increased from 16 to 42. And not only that, but there were no ulcerated plaques before, and now the patient has an ulcerated plaque. This was an asymptomatic cardiac surgeon who turned out to have left main disease, but his brother turned out to have critical stenosis as well in the proximal LAD. So, is there any additive value of CTA to patients who already have disease, who have a positive calcium score? The only real study to suggest this was published in JACC last year, in which the addition of non-calcified plaque to nuclear and CTA significantly increased the prognostic value, going from 20.5% to 30%. And finally, CTA is not yet an appropriate screening tool except for young patients with a positive family history of premature disease.
Harvey, thank you. This means sticking your neck way, way, way out. And that's what Harvey's expert in. That is, so he gets easily shot. That's an easily target for being shot, but definitely Harvey has a case. This case is a personal experience. This needs to have evidence-based medicine data to show that the screening, based on CTA, assuming that those radiation will go down and there is no problem with contrast agent. But I think Henrik Sillison made a great presentation that we don't know how much plaque they have in their carotid. If these people can get a 5-minute carotid or 10-minute carotid exam and show a tremendous amount of plaques, then Harvey, why would you want to take them to CTA? Because you wouldn't. No, that's good. Well, that's what I think we're in full agreement. That the screening needs to take into account all aspects. And here he's doing it on a very selected group of people. And the most important question for everybody is how much radiation they're getting. And Dan, please tell us what's the horizon for radiation? Yes.
Morning, you're 10 minutes ahead of schedule. You're 10 minutes ahead of schedule. Take that.
Then that's like you just won a lottery.
I was going to say, so you can let Dad actually give his talk. Just like 1 minute.
Then he has a microphone.
That's not even until 1:30. We have 11 minutes. Go.
After what Steve Feinstein said and all the stuff on the 3D plaque, I can hear Harvey in about 5 years saying, I'm now an ultrasound specialist of the neck, and that CT coronary angiography stuff that I used to do is terrible, based on and 15 minutes spending bashing nuclear when nuclear wasn't even part of the discussion today.
It was just an update on.
And you used to be a nuclear cardiologist. Oh my goodness.
So your number. Dad, is that you?
This slide looks at the radiation dose associated with the various kinds of studies that are present today. We generally measure things in terms of millisieverts, which is a way of estimating the effective radiation dose of various kinds of radiation procedures. The higher dose studies are the ones that that are seen here as whole body CT and nuclear studies using thallium are particularly high. The annual background radiation at sea level is about 3 millisieverts, just for reference. So I'm going to talk about CT coronary angiography a little bit, and then about coronary calcium scanning, and make this short. A few years ago, PK said, if you can provide a coronary CTA with a radiation dose of 2 millisieverts for $500, you'll have a screening test. It is a very effective test for looking at cardiac risk, and it may be that we're approaching these levels.
What about contrast nephropathy?
It's good for that too.
Renal function. Well, it's rare reform renal function, but it is an issue, absolutely.
No, we're not expanding to the kidneys here, are we?
So how much radiation is associated with these coronary CTA studies? This is a study widely recognized in JAMA from Hausleiter in 2009, showing that at that early time, coronary CTA really began around 2005, or early in the phase of the development of this procedure. Early on had about a 12 millisievert radiation, but as shown on the right part of this slide are the variations across different sites. And so there was a marked variation from site to site in how much radiation was associated with coronary CTA. Gil Raff, knowing this, set up a registry in Michigan in which everyone in the state of Michigan, in order to get Blue Cross to cover this coronary CTA, had to take part in a registry. As part of the registry, they reported their radiation doses, and then there was feedback about how they stood compared to the other centers given, and there were approaches given to the people to how to improve their radiation doses. In the control period, and then the intervention period followed, and finally in the validation period, there was a marked change in the amount of radiation associated with coronary CTA. And the overall reduction was 53% reduction over time during this course of that registry. The way in which the radiation is reduced is a combination of factors. One is the use of lower tube voltage. Generally, the voltage has previously been at 120 kVp. Hausleiter demonstrated 100 kVp in patients who are under body mass index of 30. Gave excellent images as are shown here. And he demonstrated that the image quality shown on the left was no different at this reduced voltage, whereas the radiation exposure shown on the right was reduced by 40% by the use of 100 kVp. This has become the standard in CT in the patients who are non-obese to be using the lower dose, the lower voltage approach. The second approach that's employed is with the standard, what we call retrospective gating technique for CT, is to use dose modulation. And instead of having the tube current turned on throughout the cardiac cycle, which is the way CT started, you turn it on only, have full tube current only for a portion of the cardiac cycle. We took that to the next step further, taking the retrospective technique to its maximum by having full tube current targeted only at the 70% level of the RR interval. There's a reduced tube current of 4% through the remaining part of the cardiac cycle. This is what one of my fellows Ariel Getstein. We use that approach to tailor. We use the heart rate, the patient's body mass index, and the amount of calcium in their coronary arteries to tailor the procedure to the individual patient. And what we were able to achieve is that in smaller patients with a regular rhythm, we had an average dose of 4.4 millisieverts. So you can see we're starting to get down to very low levels, approximating those that Dupree suggested would be needed for a screening test. Well, the whole thing really changed when prospective gating became common. It now makes up approximately half of the CT that's going on in the country. And for this approach, full tube current is used only at one phase of the cardiac cycle. And a sequential set of images are obtained without overlap between regions as is associated with helical scanning. So this is called sequential scanning or prospective ECG triggering. Hausleiter, again, has really been taking the lead in radiation reduction with CT, has started, actually performed a study called Protection 3, not yet published in manuscript form, in which he compared, in a randomized trial, sequential gating shown on the top to the standard spiral technique shown on the bottom. Again, what he did is just that he had in the earlier study, he took randomized patients to to either having sequential CTA, that's the prospective gating approach, or to having spiral CT, the one that has been generally used in the past. Looked at image quality and radiation dose over the course of the study. In terms of image quality, the prospective gating was equal to the spiral approach, and importantly, there was a dramatic reduction in the radiation exposure using this technique that only has the radiation exposure during the time of the cardiac cycle that's needed. Taking that a step further, there's a newer approach called high-pitch spiral flash, in which this sequential scanning is done during a single heartbeat. And with this approach, it's been reported by Leszka et al. In the European Journal of Radiology, 35 patients, small study, brand new equipment. And we see that the beautiful demonstration of the coronary arteries with a mean radiation dose of 0.9 millisieverts, getting down to 1/3 of the background radiation levels. Everything I talked about it dealt with what's called filtered back projection as a way of handling the CT data. And it's been known in tomographic world, it's in specs, PET, CT, that iterative reconstruction is a superior way of getting information from CT. It allows you to have fewer photons or fewer data entry points and end up with images of similar quality. So the iterative reconstruction is going to reduce by 30 to 50% the amount of radiation associated with coronary CT angiography. And iterative reconstruction is now just coming on the market. It's been on the market for a couple of years with one vendor, and now all 4 vendors have this iterative reconstruction associated with reduction in radiation. So I think that all of the hoopla, all of the publicity that's been out there about how bad CT is has overstated the case. In response to that publicity, though, and all of the hoopla, the CT community has gone in the direction of doing everything possible to reduce dose, and it's down to extremely low levels. Let's look at coronary calcium scanning. A similar thing is happening with coronary calcium scanning. Coronary calcium scanning it was looked at in a variety of different scanners just to survey what was happening a couple of years ago by the group at Columbia. They found that the average dose of coronary calcium scans at that time was 2.3 millisieverts. Again, we're less than background. It's a low radiation study, but it's getting even better. We published a study which we demonstrated that we could reduce down using this 100 kVp approach instead of the previous approach. We could reduce again by about 40% the radiation burden associated with CT, with calcium scanning, and our dose got down to 1.2 in this study. This did not use iterative reconstruction, and it did not use special windowing of the field of view that has now been applied to the within the MESA trial. I guess finally, just to give you some very recent data, looking at high-speed, high-pitched helical scanning with the flash system. That was the one that I showed you that got the information in a single beat. Stefan Achenbach's group has shown that with either of the voltages that I talked about, calcium scanning can now be performed at levels of 0.2 and 0.3 millisieverts of radiation. Matt gave me a slide that somehow didn't get into this, into the packet that I'm looking at. I put it on the other one, I didn't have it on this one, that shows what's happening in the MESA trial. And in the MESA trial, Matt, you maybe just could state what that slide shows.
So we're using it's a screening, 4 different scanners, 8 different sites. We have doses of 1.2 millisieverts, 1.1 millisieverts on average, using 120 kV. We haven't gone down to the lower voltage yet because it changes the calcium score a little bit, and we're afraid to do that in MESA since we're following up patients. But the dose that will be reported from all of these multi-center studies for asymptomatic people is 1.1 millisieverts.
And that's without the iterative reconstruction?
That's without any flash or iterative reconstruction, which would
Right.
take it down by another 50% or more, as Dan showed.
Right.
And
So the current standard for screening, if you were to use this in asymptomatic patients, the way we would go for coronary CTA would be to do prospective imaging. And even today, for coronary CTA, it's less than 3 millisieverts for that procedure, and it's less than 2 millisieverts for coronary calcium scanning. But what Matt's telling us is that with the most recent, even minus this iterative, just with the newer approaches to calcium scanning, based on what Matt's saying, based on the kind of data that we've seen, we're down to 1 millisievert for the coronary calcium scan. Given that, I'd just like to summarize that I think the issue of radiation exposure with screening with coronary calcium is not an issue for the age group of the patient population that we're talking about.
So just to put that in further perspective, if I can, a mammogram for a female is 0.7 millisieverts per year, per study. So over 5 years, if we did even 2 calcium scores as SHAPE proposes, that's 2 millisieverts. According to the American Cancer Society, a woman should get 5 mammograms, which would be 3.5 millisieverts. According to more conservative estimates by the screening for mammography, they would get it every other year, which would be 3 mammograms, and that would still be at the same dose. So we're giving the same dose to a female that we get just for getting mammography, and cancer and heart disease is 10 to 1 versus breast cancer for cause of death.
can you compare it to dental exam?
Dental exams depends on how many shots, but generally it's about 0.4, 0.5 millisieverts. So if you get a dental exam twice a year, that's beyond a calcium score by far. By
Well, as
far.
you know,
I don't go to the dentist twice a year for that reason exactly. I'm afraid of radiation.
mammography is not quite free either. They are also targeted by the anti-radiation campaign that mammography is also, a point of doing more harm.
Right, the debate between every year versus every other year, but not a debate of not doing it. So,
Yeah, especially when we're going,
Right.
3 to 5 years with these. Now, the second question is how quickly these new developments that are in your lab or Stefan's lab, Matt's lab, are going to be available in every Joe Blow's clinic.
Go ahead.
I was going to say, I think the 100 millisievert the 100 kV that Dan is first to publish will take a while to permeate because it changes the calcium score. And we need to be able to adjust it back to all of these data sets that Paolo showed of 35,000 and 45,000 patients.
By how much on it?
Actually, no, that doesn't change the score.
If you
It
change
requires
the
a change in the
right.
threshold.
So you have to change the scoring, you have to change the computer scoring system to get a similar score.
However, I think what will become more widespread is that because of that, changing the threshold might have to be tailored to individual cameras.
Right.
So I think it's probably going to stay at 120, but instead of using the higher MAS, the current that we've been associated having to use, or that was established many years ago, reducing the MAS is now possible, and that's what's happening within.
And that's what we're doing now. And that's already widespread and easy to do, and that doesn't change the score.
Right.
So that's safe. And then the newer scanners, each newer scanner lowers the radiation dose stepwise. So we're getting better and better. I would safely say we can publish that the average doses are in the 1 range for a calcium score. That will correlate with what we published from the NIH studies. So in the SHAPE-2 algorithm, we could say this is a millisievert exam, not much more than a mammogram or a couple trips to the dentist.
Okay, we're moving on to, thank you, Dan, moving on to the PAD part of the presentation. So PAD, as you know, we've taken carotid, we've taken coronary, and now we're going to peripheral, here focusing on femoral and disease measured by ankle brachial index. And so in the next two presentations, are you combining two slides?
We are. We
You
actually
are.
got
That's
them all
perfect.
together.
Perfect. So we will learn the status of ABI screening, the criteria, the adoptions, and about the Society of PAD Coalition. Please go ahead.
Perfect, thank you. Okay, first of all, we're going to talk about the PAD Coalition, and then we talk about the ankle brachial index and the guidelines, and Kirk and I are just going to do this together back and forth. The coalition actually was established back in 2004, and it's a public interdisciplinary coalition devoted to creating a national public awareness campaign, which we've done. And we also are focusing quite a bit on public and physician education as well. So we started out many years ago with 15 organizations, and I'm going to show you some timelines, which I know you'll find interesting, and I think it's going to make you guys feel good. We now are up to 84 organizations that overall represents over 1 million healthcare professionals and 600,000 consumers. I want to make a point here and say that the PAD Coalition is under the umbrella of the Vascular Disease Foundation. Okay, so if you go to look for it, we do have our own website, but it is under the umbrella of the Vascular Disease Foundation. So what's the mission? Our mission is simple. It is to improve quality of life, save limbs, and save lives. And we're committed to the prevention, early detection, treatment, and rehabilitation of people with or at risk for PAD. So why do we need a coalition? I think we know a whole lot more about PAD today than we knew 5-10 years ago, and we know that people continue to suffer the consequences of preventable cardiovascular disease, which we've been hearing about. And we know that health improves and society benefits when people have good information, and we know we can improve outcomes as well. So here's the perspective, and this is what I wanted to show to you, is we started this back in 1995. So when you guys look at your 4 years old, we've been trying to get this together for a long time. So from 1995 to 2002, all the societies across the U.S. sort of did their own thing, and this is some intersocietal efforts that you see there. I was the president of SVN in that time frame, and that's the Vascular Nursing Group, and we had the Step Ahead program. That was an ABI screening program where we did, screenings in malls, did training in doctors' offices, etc. And then actually Society for Interventional Radiology had their Legs for Life, which they still have ongoing. The American Vascular Association had screening carotids, aorta, and legs as well. And the Society for Vascular Medicine and Biology, as well as the AHA, had their initiatives. This was our first summit where we all got together in 2002, and we had, my first encounter with this group was back in August, where a group of us got together in Bethesda and had our first meeting. Honestly, I felt like I was in a room with a bunch of pit bulls. Everybody wanted their own territory. Nobody wanted to give up anything. So, it was a long, tedious process. So the outcome of our August meeting went on to, we got NHLBI involved, and we had our first strategic planning meeting on PAD public education in 2003. And in 2003, a bit later in that year, we had our meeting. And as I mentioned, 2004, we put our coalition together, and this was a group of individuals. Like I said, we started out with 15 people, basically. And we put together and had our campaign, etc., and we had our first inaugural meeting in DC in 2004. I'm going to go through these fairly quickly for you, but just to kind of give you an idea. NHLBI, we were very fortunate in securing $3.5 billion from NHLBI to develop our Stay in Circulation campaign. We worked very closely with Ogilvy International, who was an amazing PR agency to work with, and developed our awareness campaign. And again, this was focused, targeted to the public. As you all know, the guidelines came out in 2006, and this is very much how we do follow the guidelines and how in treating patients. And then in September 2006, we had a launch of that campaign, and we also declared September as PAD Awareness Month, and that's an annual thing that has been ongoing since. As I mentioned, the campaigns went on for 2 years, supported by NHLBI, and they turned it back over to the coalition, which we continued. And Kirk is going to show you some really amazing pictures we have targeted to the public to promote awareness and really scare people about PAD. We're now, like I said, we've grown. We're comprised of 84 organizations. This just shows you a coordinated effort to inform the public. We work with NHLBI. We have 84 member organizations across Canada and the US who have really, we've come together as a unified voice, and we're certainly getting a lot more attention and speaking one singular voice than each group doing their own thing. The Stay in Circulation campaign, like I said, it was the first national awareness program which was targeted to the public. We were targeting people over the age of 50, and we really wanted to step up awareness. And it was a catchy logo we had: Stay in Circulation, take steps to learn about PAD. There's numerous information that was you've seen on TV, as well as radio and advertisements, fact sheets, posters. We had a lot of public service announcements, and we have educational DVDs, etc. Now I'm going to turn it to Kirk to talk about the other educational materials that we promote to our member organizations.
Thank you. It was thought that some of the information patients didn't really know about ABIs and PAD, so a lot of the educational stuff was geared towards the public as well as physicians. This is one of the sheets that's used as a wall display that can go in a physician's office in the waiting area, as well as tear-off sheet to display information about PAD and some fact-finding information. It's just some other brochures as it relates to saving limbs and lives through the coalition. And just more information. It was thought that we would try to get the word out as much as possible to other physicians and to the public as well. These are some life-saving tips, just information on what is PAD, what are some of the symptoms, what are the risk factors, the common signs that individuals can have as it relates to these kind of problems. We also did some ad campaigns at public transportation, whether it be the bus or the subway, as well as the airport in DC. You can see this one relates to heart attack, stroke, amputation, and death. Peripheral arterial disease is no walk in the park. I just thought that some of the ads that were out before were as thought-provoking or striking. Obviously, amputee focuses the PAD outcome. They say as we age, we lose an inch or two. Sadly, those with peripheral arterial disease sometimes lose a whole foot. And again, the same kind of information using a different format. And back to the walk in the park again. So what is PAD?
Okay, do you have any questions? That's sort of our background of the coalition.
That was
Did you want
excellent,
to?
because we were, on our end, the Shape Society, were not preview to a lot of things. Now, you said 81 organizations.
84 organizations.
Are those non-profit or mixed profit?
Both.
Both.
Yeah.
So companies as well as non-profit organizations.
Correct.
That's quite interesting.
Yeah.
I mean, that mix was...
It's primarily, like most of our groups are like medical groups, like the Society for Vascular Medicine Biology, the American Heart Association, Surgical...
American Heart Association is included?
Yes, yes, Society for Vascular
and then
Surgery.
Companies like Boston Scientific and all others are also included in 84?
Yes.
PAD Coalition?
Yeah. There are corporate sponsors, they are. This is all member organizations.
But Boston Scientific is one of those 84 organizations?
No, they're not actually. That's our corporate sponsors. Our sponsors are not.
So this 84
is all
non-profit?
correct.
They're all non-profit societies, organizations?
Yes.
Okay. Any questions here? You want to move to ABI now?
Yeah, we're going to talk a little bit about PAD. Just have a few slides because we haven't talked about it, so we thought we'd just throw in a few. So what it is it's the presence of stenosis or occlusion in the leg arteries. It can also occur in the upper arms as well, and it's caused by the same systemic disease process of atherosclerosis. And I think you all know that PAD is common. As everybody ages, we're going to see more and more. But the big message is that it's associated with a very high cardiovascular risk. Heart attack, stroke, death, functional impairment. A lot of these people have their legs amputated as shown in our pictures. It's very common. This is from the Canadian Cardiovascular Consensus Statement, but it's very, very common. There's about 9 to 12 million Americans, 800,000 Canadians. But the big thing with these people is over half of them are asymptomatic, meaning they don't have the classic signs and symptoms of the pain and aching in their calves that comes on with exercise and goes away when they stop walking. So it's underdiagnosed and undertreated compared to other cardiovascular diseases. It's a major health burden. Patients with PAD are 6 times more likely to die within 10 years. They have a very much decreased quality of life, and their survival, like I said, is similar it's pretty close to patients with lung cancer. The magnitude of the problem, like I said, is it's age adjusted. The older you get, your chance of having or getting PAD increases. It's one of the leading healthcare costs by diagnosis, and there was 2 papers published on lack of awareness. There was the Canadian paper and the American paper, which showed very similar, strikingly results back in 2008 and 9. In Canada, it was 2/3 of the public had never heard of PAD. In the U.S., it was 3 out of 4, 75%, so it was very high. The 2 major goals: we want to improve their quality of life, decrease cardiovascular outcomes, and preserve limbs and life. And this, I think you guys know, is these people, their quality of life is not good at all. They just can't walk, and they range somewhere between heart failure and lung cancer when it comes to quality of life. So the ankle brachial index is the diagnostic tool for measuring peripheral arterial disease. It's a non-invasive, objective measurement, and what it is the ankle systolic pressure ratio compared to the arm systolic pressure. And this just shows you, we put a cuff around the ankle. I'll just show you here. The concept is that your arm pressure and your ankle pressure should be the same, and therefore it should be a ratio of 1. It's diagnostic of PAD if it's less than 0.9. So it's performed with the patient resting. All pressures are measured with the Doppler, and that's a handheld Doppler. Both pressures are measured, and we use both the dorsalis pedis and the posterior tibial arteries. And this is just an example showing the calculation. And like I mentioned, anything less than 0.9 is diagnostic of PAD. With any test, the ABI does have its limitations. You can get inaccurate results with diabetics and patients who have renal failure as well, as their vessels are non-compressible distally, and it can be very insensitive to mild occlusive disease. Kirk is going to talk about some other alternative non-invasive tests, and I'll leave that piece for you. And when you compare, looking at the sensitivity and the specificity of the ankle brachial index compared to other very common tests that are done in primary care, you know, the mammogram, it's much more sensitive and specific. And this is from Dr. Belch's article, but I also looked at other articles that had used it, and it was used in the ERIC study as well. The ABI found to be very sensitive and specific, as well as in the partner study, which was done a few years ago, about 10 years ago. So detecting PAD is really important. These patients need to be aggressively managed, as was discussed earlier this morning, with risk factor management. And again, we follow the guidelines for that. These are some of the screening programs that we talked about: the Step Ahead program, the Legs for Life, the Carotid, and we do have an ABI registry, which is a list of nurses who are certified to do the ankle brachial index across Canada and the U.S., and we have ABI workshops at all of our meetings. So I'll pass it over to Kurt. Do you have any questions thus far?
No, I think that we're very interested to know the link, as you saw in SHAPE, the link from diagnosis or screening to treatment, and how the PAD correlation recognizes is purely non-invasive systemic drug therapy, or there is an exit for interventional therapy in the asymptomatic population, and how is it in the symptomatic versus asymptomatic population? Because that's really the core of the matter. If somebody is symptomatic, they'll go to the doctor and they get, but if you find an asymptomatic, and I suspect that's where you have problems with the U.S. Preventive Task Force, that you cannot get their support on that. So perhaps you can let us know what your latest thoughts are. And after, let's talk about your presentation, and at the end we want to know, how do you plan to challenge the barrier that is in your way to get adopted for asymptomatic population?
I'm going to go on to talk about why PAD guidelines are important. Obviously, this would increase or enhance a person's quality of patient care, also bring other importance to other atherosclerotic lower extremity things that relate to PAD, whether it be prevalence, cardiovascular risk, and quality of life, and to also improve ability to detect and treat renal artery disease as well as AAA in this patient populations. When it comes to looking at the guidelines, steps towards a diagnosis, we're looking at recognizing the risk factor groups that lead to recognition of 5 main areas. We want to keep in mind, obviously we talked about history before, we obtain a history of walking impairment as it relates to limb ischemia, obtain a vascular review of symptoms. Is there any leg discomfort with exertion or leg pain at rest? Does the individual have any non-healing wounds or gangrene? And then we're going to look at whether there's no leg pain at all, atypical leg pain, classic claudication. Usually a smaller percent will have critical limb ischemia or acute limb ischemia, and go on to perform the resting ankle brachial index measurement. When defining those individuals, we can include several categories. If the individual is greater than 40 years old with one of the additional risk factors that have been talked about, or 50 to 60-year-old, whether it be male versus female with risk factors. And obviously anyone over 70 years of old is going to get dinged for anything. I'm losing my hair at 50. You guys were talking about 75 earlier for some of your testing. So the older we get, unfortunately, a lot of things happen to us. Leg symptoms with exertion, suggestion of claudication or ischemic leg pain. Is there any abnormal pulses in the lower extremity? And obviously a history of any of the atherosclerotic diseases. Best summary statement to date would be focused on physicians' attention towards the severity of increased risk of peripheral arterial disease. And PAD has severely been underestimated for many years, often considered as a minor problem without any major consequences. Methods of measuring can be a handheld Doppler, or one of the systems that's out there is a PADNet system currently. We've heard a lot that goes along with ethnicity. Individuals over the age of 60, according to this study, looked at African Americans and saw that they were 2 to 3 times higher than non-Hispanics as it relates to having some PAD abnormalities. The one on the top shows men, African American men, and you can see here where it starts to split out after 50. And underneath is Hispanic men. What's interesting is correlation of African American females and Hispanic females over the age of 50 are pretty close when it comes to the diagnosis in this patient population. Obviously, if there's other testing that's involved, if there's question of ABI limitations, which would include pulse volume recordings, Doppler waveforms, duplex ultrasound, or any of the other CT, angiography, or MRA in these individuals with abnormalities. It's just an example of what the pulse volume recordings would look like, and you can see the difference in the waveforms on what is your right here as it relates to below the knee. Again, some examples of segmental volumes where you can see the difference of possibility of a lesion between the upper thigh and the lower thigh here with the pressure changes, as well as in the calf and the ankle here, which is suggestive of abnormalities.
Do you need to have those as part of a screen? Do you need to have pressure volume?
No, it's just a form of completeness for the top. It's not a screening
So as far
tool.
as the screening, you recommend just do the ABI, and then you recommend for the next step.
That's
Which
correct.
would include
Right.
identifying where is the
Right, that's right.
The location of the steps.
So the target population in asymptomatic individuals will be age less than 50 years with diabetes or one of the other risk factors, 50 to 69 with a history of smoking or diabetes, and 70 years old regardless of any risk factor profile of the asymptomatic population versus the symptomatic individuals would have leg symptoms with exertion, which may be suggestive of some claudication or breast pain. What's interesting is what we found is that we started working with the National Minority Quality Forum, which developed the PAD Atlas, and in the United States, there are 38,000 zip codes in the U.S. Of those 38,000 zip codes, what was found is that 8,615 zip codes, 67% of the people lived there, resided, had PAD. Of that same amount, 80% were over the age of 65. And in that same category of zip codes, 87% were African Americans with PAD. So we looked at my area, I'm from DC, and we found that the national average for individuals with PAD in the United States was 5.25%, and the District of Columbia falls into the category of 9.05% or greater. So it's almost twice.
Is
Yes.
that percentage or incident?
No, that's percent.
5.2% have PAD positive?
Of the population,
National population.
older patients, right? It's driven by age.
Right.
No.
That's correct.
All adults greater than 40.
All
All
adults
adults.
greater than 40?
Very high.
Yeah, but that's
way
80
high.
year olds, right? I mean, there's a lot of PAD in
Yeah.
those patients.
It's much, it's high.
No, but even in her slide, when she gave the incidence in Canada and the US, 1.1 to 2 million people in the US, you said?
9 to 12.
9 to 12
Nine.
million
People in the US have PAD.
half of them are asymptomatic.
What are you going to do with them? Let's say we detect it with, it's just like coronary calcium. What your recommendation for therapy? I'm just very anxious to know what we're going to do with these. We can't send them, interventional. What are we going to do with these? And they're
But
asymptomatic.
that tells you that ABI is a very effective. I mean, we discussed this earlier on, that if you have a positive ABI, chances are you will have a positive flag and a positive
Right.
flag.
So they would go down the line of shape where it would be aggressive systemic therapy. Basically,
Right.
bring them down their LDL to,
Yeah.
okay.
When we pick up PAD and someone, we manage them as aggressively as if they've had a heart attack or stroke, because most of them may have already had it or are going to have one in the next 5 to 10 years.
Okay, so you basically say CHD equivalent.
Exactly, that's right.
NCB, right?
Yeah.
And see, right.
NCB says that.
Yeah.
PAD.
What about the severity of it? See, remember in SHAPE guideline, you see positive coronary calcium or INT more than 50th percentile is one step. But then we branch them and say we treat according to severity of disease. Do we have something like that in PAD guidelines? That you would be ABI of 0.8 to 0.9 and versus 0.7 to 0.8, get different level of LDL targets and so on. We don't have that currently
Yeah.
in you.
We
And then
don't.
that would be a challenge for SHAPE to integrate that into SHAPE. Okay. That's pretty exciting. That is really missing. I think that's been very much missing. in
It
PAD,
is
that
very
you basically, you tag somebody who is a ABI of 0.89 or 0.9 and somebody who is 0.7, 0.6, both asymptomatic, you tag them the same and you're not distinguishing them basically. Just like somebody with coronary calcium 700, coronary calcium 50, we're looking at the same way. We don't. We put them on 2 different scale of risk and treatment. Please go ahead.
So what's next is obviously a better inclusion by Medicare for non-invasive testing for at-risk individuals to also increase or continue to increase patient education, physician education, healthcare workers, and government.
Great. Is that the last slide?
Yeah.
Okay.
Oh, that's it.
Excellent. Thank you. This was a really good